antiviral drug.
Very dense.
Yeah, but our mission today is to extract the brilliant strategic ways modern medicine hunts down these microscopic hijackers. And we're going to do it without overwhelming you with a mountain of medical jargon.
That's the goal.
Because the core problem we're looking at today is, well, it's basically a hostage situation. Treating a bacterial infection is kind of like fighting invaders who have pitched a bunch of tents on your front lawn.
Right, they're outside.
Exactly. They're clearly distinct from your house. They are out in the open, and you can target those tents relatively easily. But viruses, they're inside the house.
They're already in.
Right. So how do the chemical cops, our antiviral drugs, take out the burglar without burning down your entire home in the process?
Well, you're touching on the fundamental hurdle of antiviral pharmacology. The clinical term for viruses is obligate intracellular parasites.
Obligate meaning they have no choice.
Right. They're incredibly stripped down. Unlike bacteria, which have their own cell walls and can carry out their own metabolic processes, viruses have practically nothing.
Wow.
They are essentially just a string of genetic code wrapped in a protein shell. Because they lack the machinery to reproduce on their own, they have to hijack yours.
Right.
So designing a drug to stop them is a massive catch-22. Any chemical that shuts down the virus's replication process is highly likely to damage the host cell's normal functions at the exact same time.
That makes total sense. If you poison the factory, you poison the worker too.
Exactly. And on top of that, you have a severe timing issue. By the time you actually feel clinical symptoms, the sudden fever, the body aches, the deep fatigue, most of the exponential viral replication has already happened.
Oh, wow. So you're already full of the virus by the time you feel sick?
Right. You are largely feeling the inflammatory aftermath. It's the immune system's response to the wreckage.
Okay, so if the burglar is already inside the house wearing our clothes and multiplying before we even realize we're sick, where do we even begin to fight back?
We look at the logistics of how the burglar gets in and out. Since a virus absolutely relies on breaking into our cells, unpacking its instructions, and then bursting back out to spread, the first major pharmacological strategy focuses on the doorways.
The doorways?
Yeah. This is especially relevant for respiratory viruses like influenza A.
Okay, so let's start at the front door. How does a drug actually stop a virus from getting inside the cell in the first place?
Well, when the influenza virus is swallowed up by a host cell, it's initially encased in this little bubble called an endosome. But just being inside the bubble isn't enough.
It's just sitting there.
Right. For the virus to actually infect the cell and take over the factory, it has to unpack its genetic material. It essentially has to open its suitcase. And the biological trigger for opening that suitcase is acidity. The virus relies on the highly acidic environment inside that endosome to dissolve its outer layer.
So if the virus needs a rush of acid to unpack, how do we, shut off the acid?
We use drugs that physically plug the pipe. There are two older antiviral drugs detailed in the text amantadine and rimantadine.
Okay.
Influenza A has a specific membrane protein called the M2 protein. You can picture it as a tiny microscopic channel on the surface of the virus.
Like a little tunnel.
Yeah, a tunnel. Its sole purpose is to allow hydrogen ions, which are what make an environment acidic, to flow inside the viral particle. Amantadine and rimantadine lodge themselves directly into that M2 channel.
They just jam it up.
Exactly. They block the flow. Without that internal rush of acid, the virus can't unpack. The suitcase stays permanently locked, and the infection process within that specific cell just stops.
Okay, so that covers the entry, the unpacking. But what about the back door, like the exit? The text highlights a totally different class of drugs for this. Things like oseltamivir, which is widely known as the oral drug Tamiflu.
Right.
And Zamivir, which is inhaled.
Yeah, so those target the final stage of the viral life cycle. Once a cell has been fully hijacked and forced to manufacture thousands of new virus particles, those new virions have to leave to go infect neighboring cells.
Is to break out.
Right. They push out against the host cell membrane, but they remain tethered to it. To finally break free, they require a specific viral enzyme called neuraminidase.
Neuraminidase?
Yeah. It essentially acts like a pair of molecular scissors to cut the tether. Drugs like oseltamivir and zanamivir bind to that enzyme and disable it. They hide the scissors.
But wait, if the host cell is already completely hijacked, filled with thousands of viruses, and dying, why do we even care about gluing those viruses to the exit? Isn't the battle for that specific cell already lost?
Oh, the battle for that single cell is absolutely lost. But you have to view it through the lens of exponential mathematics. It is about preventing the domino effect.
Ah, I see.
If that one dying cell releases 10,000 new viruses, those 10,000 will immediately infect 10,000 healthy cells nearby, which will soon release 10,000 more each.
That is terrifying math.
It is. By permanently gluing those newly minted viruses to the surface of the dead cell, you halt that geometric progression. You basically contain the fire to one room.
Which buys the body time.
Exactly. It gives the host's innate immune system the critical hours it needs to spin up its own targeted defenses and clear the infection.
That makes total sense.
But, this is exactly why the timing window is so notoriously narrow. Because of how fast influenza replicates, drugs that hide the scissors really only provide a clinical benefit if they are administered within the first 24 to 48 hours of symptom onset.
So you have to be fast.
Very fast. If you take them on day 4, the exponential spread has largely already occurred.
Wow. Now, there's also a really striking warning in the pharmacology text regarding how these drugs are delivered. Like zanamivir is administered intranasally. It's a powder you inhale directly into your airways.
Yes.
But the text aggressively stresses that it must be avoided in people with severe reactive asthma or chronic obstructive pulmonary disease.
Right, because the localized delivery mechanism is a double-edged sword. Putting the drug right where the virus is replicating makes a lot of sense.
Because it's a respiratory virus.
Exactly. But the physical powder and the chemical itself can severely irritate the airways. For an asthmatic patient, that irritation can trigger a massive bronchospasm, a sudden constriction of the airway muscles, which can actually be fatal.
Oh, wow. That is a serious risk.
It is. Oseltamivir avoids this entirely by being an orally active prodrug.
A prodrug meaning it's essentially inactive when you swallow it.
Correct. You swallow the capsule, it passes safely through your stomach, and when it hits your liver, your own metabolic enzymes process it into its active antiviral form.
And then it goes into the blood.
Yeah, which then circulates in the blood. It completely bypasses the sensitive tissues of the lungs.
Okay, so blocking doorways and hiding the exit scissors makes total sense for a fast, hit-and-run virus like the flu. But what happens when a virus decides to move in permanently?
That's a whole different game.
Right. I'm talking about viruses that establish a lifelong presence in your body, like the herpes viruses or hepatitis. You can't just jam the door anymore. They are already entrenched.
You can't.
You have to somehow sabotage the factory floor itself.
That requires a monumental shift in strategy. You can't just contain them. You have to break their internal replication machinery. The classic example in the literature is the treatment of herpes viruses.
Okay.
Specifically herpes simplex virus and varicella zoster virus, which is responsible for chickenpox and shingles. The cornerstone drug for this family is acyclovir.
This was easily the most fascinating mechanism in the entire source text for me.
Really?
Oh yeah, it reads like a molecular heist. Let me try to visualize this.
Go for it.
So the virus is inside the cell, and to make copies of itself, it's rapidly building a brick wall. That wall is its new viral DNA. It has a worker running along the wall, grabbing individual building blocks and stacking them up one by one.
A very fast worker.
Right. So acyclovir is essentially a fake booby-trapped brick. It looks almost exactly like one of the virus's favorite building blocks, but it's fundamentally flawed. It's missing the crucial connector piece that allows the next brick to attach to it.
That is a remarkably accurate way to picture it, actually. The worker building the wall is an enzyme called viral DNA polymerase.
Okay.
It grabs the acyclovir molecule from the surrounding cellular suit, fully believing it's a normal, valid building block. It slots it into the growing DNA chain.
And then what happens?
Well, because acyclovir lacks that specific chemical connector, the next time the polymerase tries to add a piece, there's nothing to attach to.
Ooh.
Exactly. The entire assembly line completely crashes. The clinical term for this event is premature DNA chain termination.
It's an incredibly clever trick, but, it begs a massive question. If this drug looks so much like a normal building block for DNA, why doesn't it crash our own cellular assembly lines?
That is the big question.
Why don't our healthy cells grab the fake brick and die?
That is the genius of acyclovir's selectivity. It relies on a multi-step activation process. When acyclovir enters your body, it is completely inert.
So it does nothing at first?
Nothing at all. For that fake brick to become a deadly weapon, it needs a chemical trigger attached to it, specifically a phosphate group. Think of it like pulling the pin on a grenade.
Okay, I'm with you.
The first, most crucial step of adding that phosphate can only be efficiently performed by a very specific enzyme called viral thymidine kinase.
Meaning the virus itself has to pull the pin.
It literally signs its own death warrant. The drug enters all your cells. If a cell is healthy, nothing happens.
Wow.
Your normal human cellular enzymes are terrible at adding that first phosphate to a cyclover. It just floats around harmlessly and eventually gets flushed out.
That is amazing.
But if the cell is infected, the viral thymidine kinase enzyme unwittingly arms the acyclover, turning it into the active weapon that shuts down the virus's own replication.
That level of biological sabotage is just beautiful.
It really is elegant.
Now, the text also covers treatments for hepatitis, specifically hepatitis B and C, and the approach detailed here seems a lot less subtle than sneaking in a fake brick. They rely on a family of naturally occurring proteins called interferons.
Yeah, interferons are fundamentally different from synthesized chemical drugs like acyclover. They're actually a core component of our innate immune system.
Oh, so we already make them.
We do. In nature, when a cell is invaded by a virus, it synthesizes and releases interferons into the surrounding tissue. They act as biochemical alarm bells.
Waking up the neighborhood.
Exactly. They bind to the surface receptors of neighboring uninfected cells and signal them to rapidly raise their antiviral defenses.
So how do we turn an alarm bell into a medicine?
Through recombinant DNA technology, scientists essentially borrow the human genetic blueprint for these proteins and use specialized cell cultures in a lab to mass produce the alarm bells.
Okay.
When injected into a hepatitis patient, this massive influx of interferon forces the host cells to produce a variety of enzymes that actively chop up viral RNA and halt the synthesis of viral proteins.
The total lockdown.
It essentially creates a hostile lockdown environment across the entire liver.
But flooding the entire body with immune system alarm bells sounds like it would make you feel terrible.
It does. You are artificially triggering a system-wide immune storm. The side effects reflect the sheer force of that response.
I can imagine.
Immediately after an injection, patients experience intense, debilitating flu-like symptoms, high fever, severe chills, deep muscle aches. And with chronic use, which is required for hepatitis, it leads to profound fatigue, significant weight loss, and severe mental depression. It can even suppress bone marrow function.
So it's brutal.
It is a very heavy hammer, and it starkly contrasts with the elegant, targeted scalpel of a drug like acyclover.
Which brings us to the ultimate challenge. So acyclover works beautifully because the herpes virus is relatively stable. It falls for the fake brick.
Right.
But what happens when the virus realizes we are feeding it fake bricks? How do we fight an enemy that mutates so incredibly fast that it simply changes its disguise every single day, recognizes the trap, and builds around it?
Well, you are describing the nightmare scenario doctors faced with HIV, the human immunodeficiency virus.
Yeah.
It represents the absolute pinnacle of antiviral pharmacological challenges because of its staggering mutation rate.
Let's set the historical stage here. The sources note that prior to 1987, there really wasn't any direct medical treatment for the virus itself.
Well, none at all.
The entire focus was just on managing the secondary, opportunistic infections that took over because the patient's immune system was failing. And then we finally got zidovudine, which is widely known as AZT.
AZT was a breakthrough. It was the very first antiretroviral agent. HIV is a retrovirus. So instead of standard DNA, its genetic material is made of RNA.
Okay, so backward.
Yeah. When it enters a human cell, it deploys a specialized enzyme called reverse transcriptase. This enzyme's job is to read the viral RNA and transcribe it backward into human-compatible DNA,
Wow.
which the virus then physically splices into the host cell's own genome. AZT was designed to stop this. It functions very similarly to acyclover. It's a fake brick that gets incorporated by the reverse transcriptase, causing chain termination.
But AZT wasn't the ultimate silver bullet, was it?
Sadly, no.
Because the text points out that it was highly toxic, causing severe anemia by suppressing the bone marrow. And even worse, the virus adapted to it.
The virus adapted shockingly fast. This comes down to the terrifying evolutionary math of HIV. The virus replicates billions of times a day inside a patient.
Billions.
Yes, and that reverse transcriptase enzyme we mentioned, it is incredibly sloppy. It's like a factory worker rapidly typing out a manuscript and constantly making typos.
And those typos are mutations.
Exactly. If you apply the evolutionary pressure of just a single drug like AZT, you kill off the susceptible virus. But a few of those random typos will inevitably change the shape of the enzyme just enough that it no longer picks up the fake AZT brick.
Oh no.
Yeah, those resistant mutants survive, multiply, and suddenly the patient's entire viral load is completely immune to the drug.
So if using one drug just trains the virus to beat it, How do we outsmart a shapeshifter?
We abandoned the single drug approach entirely. Today, the standard of care is known as HART, highly active antiretroviral therapy.
Heart.
Right. Instead of throwing one rock at the virus, we hit it with a coordinated avalanche. We attack the virus at multiple distinct vulnerabilities in its life cycle simultaneously.
Let's break down how that avalanche actually works. Instead of just listing acronyms, what are the distinct mechanisms we are throwing at it? We have the fake bricks, the ones that cause chain termination.
Right.
What else is in the arsenal?
Another major class are the protease inhibitors. Later in the viral life cycle, the hijacked cell produces these long, useless chains of viral protein. They have to be chopped into specific, smaller functional pieces to build a mature infectious virus.
Okay.
An enzyme called protease acts as the meat cleaver. Protease inhibitors bind to that cleaver and jam it, so the cell pumps out new viruses, but they are defective, immature, and completely incapable of infecting another cell.
That's amazing.
We also have integrase inhibitors. These target the exact moment the virus tries to splice its freshly made DNA into the human chromosome. If you block the integrase enzyme, the viral DNA just sits there uselessly and eventually degrades.
But hold on, combining all these harsh chemicals, attacking 3 or 4 completely different cellular processes at the exact same time?
Well, actually, that sounds like a recipe for massive, overwhelming toxicity.
It's a lot for the body to handle, yes.
Right. Why not sequence them to spare the patient? Like, start with the fake bricks, and when the virus eventually mutates around that, switch to the meat cleaver jammers. It's a compassionate thought for sure. But clinically, sequential therapy guarantees failure.
Really?
Yeah. If you use them one by one, you are giving the virus the time it needs to solve one puzzle before handing it the next. You end up cultivating a multi-drug resistant supervirus.
Ah, I see.
By using hard administering 3 or 4 classes simultaneously, you force the virus to spontaneously develop 3 or 4 highly specific simultaneous mutations just to survive.
All at the same time.
Right. Mathematically, the probability of that happening drops to near zero. You trap it in a corner where every exit is blocked at once.
But the toll on the patient is real. The sources list some side effects that are honestly wild and highlight the intense struggle of patient compliance.
Very true.
For instance, the protease inhibitors can cause this intense fat redistribution, where patients experience an accumulation of fat right at the base of the neck.
Yeah.
And one of the other drug classes can cross the blood-brain barrier, causing severe dizziness and incredibly vivid, disturbing dreams.
The central nervous system effects are potent.
And then there's abacavir.
Abacavir, that's one of the fake brick drugs and NRTI, and it carries a risk of a potentially fatal hypersensitivity reaction.
Fatally.
Yes. A small percentage of patients will mount a severe allergic response to it. Fever, rash, massive gastrointestinal distress. The terrifying aspect is that if a patient stops the drug due to these symptoms and a doctor unknowingly prescribes it to them again later, that re-challenge can trigger an explosive, rapid reaction that leads to death.
Which is why the source notes there is now a mandatory genetic test, an HLA screening, to see if a patient has the specific genetic marker that predisposes them to this reaction before they ever swallow the very first pill.
Exactly.
It really shows how personalized this medicine has become.
It absolutely does. And speaking of personalized, highly specific pharmacological engineering, there's one more detail in the HIV section that is a pure masterclass in hacking the human body.
Oh, you're talking about ritonavir.
Yes, ritonavir.
Ritonavir is technically categorized as a protease inhibitor, meaning it was originally designed to jam the viral meat cleaver. But that's not actually how it's utilized today.
Not at all. Today, it's utilized almost exclusively as a biochemical booster.
A booster?
Yeah. Our livers contain a specific family of metabolizing enzymes called cytochrome P450. You can think of them as the body's garbage disposal system.
Yep.
Their primary job is to recognize foreign chemicals like medications, break them down, and clear them from our bloodstream. It turns out ritonavir is an incredibly potent inhibitor of those specific liver enzymes.
So it actively jams our own garbage disposal.
Precisely. In modern heart regimens, doctors will give a small subtherapeutic dose of ritonavir alongside a different primary protease inhibitor.
Oh, that's sneaky.
Very. The ritonavir occupies and shuts down the liver's disposal system. Because the disposal is jammed, the liver can't clear the primary drug.
Wow.
This allows that primary medication to remain in the patient's bloodstream at much higher concentrations for a vastly longer period of time.
That is a brilliant hack.
It really is. This hack means the patient can take fewer pills, less frequently throughout the day, while maintaining the steady, relentless chemical pressure needed to keep the virus from mutating.
Okay, let's take a step back and look at the incredible journey we've been on today.
It's been a lot of ground covered.
It has. We started with this seemingly impossible hostage situation, fighting an enemy that uses our very own cells as its armor in its factory.
Right.
We looked at how we can try to block the doorways and the exits with respiratory viruses, trapping the flu so our immune system can sweep it up.
The doorways and the scissors.
Exactly. Then we explored the brilliant elegance of tricking herpes viruses into building their own booby-trapped DNA walls with a cyclover. We saw the heavy systemic toll of sounding the interferon alarm bells for hepatitis.
The heavy hammer.
Yeah. And finally, we saw the sheer overwhelming force required to fight a shapeshifter like HIV, launching a simultaneous multi-class pharmacological siege and even hacking our own liver's garbage disposal just to outpace the terrifying math of viral mutation.
The evolution of these therapies is a true testament to human ingenuity. But, looking at the mechanisms we've discussed today, particularly a cyclover, it leaves us with a truly profound question about the future of all pharmacology.
How so?
Well, we've proven that we can design a prodrug that is completely harmless to human tissue and use the disease's own unique enzymes to pull the pin and turn it into a weapon.
Right.
Could this specific Trojan horse strategy be the key to moving beyond viruses?
Oh, wow. Like applying it to other things.
Exactly. Imagine if we could engineer targeted therapies that float inertly through the bloodstream until they physically bump into the unique mutated proteins of a rapidly dividing cancer cell.
That would be revolutionary.
Or the specific enzymes of a highly resistant bacterial superbug. If we can consistently make the disease activate its own destruction, we could theoretically eliminate the devastating systemic side effects of broad-spectrum antibiotics and chemotherapy entirely.
That is an incredible thought to end on. Taking the lessons learned from fighting viruses and using them to design the ultimate smart bomb for all disease.
It really is the holy grail.
Thank you so much for joining us on this deep dive. And to you listening, the next time you find yourself swallowing a simple antiviral pill for a winter bug, just remember, you aren't just taking medicine. You are deploying a highly targeted, mathematically precise piece of molecular sabotage. Catch you next time.